adynamic bone disease. When it is a high turnover, abnormal mineralization is mixed uremic osteodystrophy. When it is high turnover, normal mineralization and normal volume, it is mild HPE. When it is high turnover, normal mineralization, high volume, it is otitis fibrosa. This is the bone histology picture. I have never seen a bone histology. This is downloaded from the internet. The first one, the A, is the bone normal bone. The second one, B, is increased osteoblastic and osteoblastic activity, and that indicates a hyperparathyroid bone. The third one, which is C, has got no cells in it. It is adynamic bone disease. D and E, osteomalacia, aluminium bone disease. And F is mixed uremic osteodystrophy. Before I conclude, I want to say a few words about fibroblast growth factor 23. This is an emerging marker and probably will be a marker in future. FGF23 is secreted from osteocyte. It acts on the kidney and causes phosphatemia. It decreases the PTH secretion, and by independent action, it has got action on cardiac remodeling as well as vascular calcification. If you see this study from Kidney International 2012, FGF23 starts rising very in CKD stage 2 itself, and it could be in future the early marker of CKD NBD even before phosphorus and PTH start rising. Now, are we very clear about diagnosing CKD NBD with all these guidelines? I still have a dilemma. When there is short of bone biopsy, if you have got a hyperphosphatemia, hypocalcemia, and high PTH, do we label it as a high turnover bone disease? If there is a hyperphosphatemia, hypercalcemia, and low IPTH, do we call it adynamic bone disease? Vitamin D low or normal in a cow setting, what's the interpretation? I exactly do not know. So, with our guidelines, still we have some doubt, but we have some guidelines to follow. I think further studies are required to refine this guideline. Thank you.
Distinguished delegates and dear friends, at the outset, let me thank the organizers for this kind invitation. As we have already heard, CKD developmental disorder is a systemic disorder which is characterized by a constellation of abnormalities which include laboratory abnormalities, bone abnormalities, and vascular calcification. In the next 15 minutes or so, I shall concentrate mainly upon various strategies to prevent or normalize the laboratory abnormalities which are responsible for the other two, the bone abnormalities and vascular calcification will be led by the next speaker. The important laboratory abnormalities are abnormalities in phosphorus, calcium, vitamin D, and PTH and probably FGF23 also. Abnormalities can contribute to the secondary hyperparathyroidism, which in turn can cause not only changes in the skeleton but also in the non-skeletal tissue, with far-reaching consequences in the multiple systems in the body, which can lead on to long-term cardiovascular and all-cause mortality. Hyperphosphatemia is a triggering factor, and hyperparathyroidism is the central event in CKD developmental disorder. So, while discussing the treatment of hyperparathyroidism, first and foremost is the control of hyperphosphatemia. So, maintenance of normal phosphorus is the goal. As phosphorus retention starts in the early stage of CKD, even before abnormalities in the PTH or FGF23 occurs, dietary phosphorus restriction should be implemented in the early stage of CKD. The dietary phosphorus intake parallels protein intake. So it is important to limit the protein intake in the early stages of CKD before the phosphorus or PTH will start increasing. Dietary phosphorus is restricted to 800 to 1000 mg phosphorus per day. It is not uncommon to find low or normal phosphorus in many patients, especially in the Indian context. This is probably related to the high prevalence of malnutrition in them. patients with severe protein energy malnutrition. So in such situations, phosphorus binders are referred to dietary restriction. So it is important to avoid malnutrition by minimizing phosphorus in such patients, that is by choosing phosphorus from protein from plant sources, because more than 3/4 of the phosphorus in the plant proteins are in the inorganic form. It is not properly absorbed from the human gut because humans lack the enzyme phytase, whereas phosphorus present in the meats are in the organic form, it is easily absorbed. It is also important to note that it is important to avoid unnecessary dietary phosphorus, that is from dairy products, processed foods, cola, and certain vegetables. Because these foods, this aspect is a major concern to us because of our westernization of our food habits. Because the food additives which contain phosphorus is a hidden source of phosphorus for these patients. So it is very important to educate our patients about this aspect of dietary phosphorus and the need for protecting them. As the CKD progresses, diet alone becomes insufficient to prevent hyperphosphatemia. Non-compliance again is a problem in the long run. So phosphate binders are used as a CKD progresses. It is given along with means to reduce the absorption of phosphorus from the blood. Two major options available are calcium-based and non-calcium-based phosphate binders. By far the cheapest and most effective calcium-based binders in the Indian context is probably calcium carbonate and calcium acetate. The risk of hypercalcemia with calcium-containing phosphate binder is less, mainly because hypocalcemia is more prevalent in the Indian population. The added advantage of this calcium-based phosphate binder is that it provides base, the carbonate, which can utilize the metabolic acidosis and can reduce the interstitial fibrosis. In some preparations of calcium carbonate, magnesium is also added. Magnesium inhibits vascular calcification, but because of the GI side effect, it cannot be used widely. Moreover, as the GFR declines, hypermagnesemia is also a problem. The state of gastric pH is vital for phosphate binding. At low pH of the stomach, hydrogen ions will compete with phosphorus for calcium binding. Moreover, pill burden is also increased to the extent of 6 to 8 tablets per day. So currently the KDO recommends the intake of elemental calcium be restricted to less than 1500 mg per day from supplements and from diet less than 500 mg per day. So altogether the dietary restriction, the elemental calcium intake in the diet should be less than 2 grams per day, especially if the patient is taking vitamin D steroids. Inadvertent use of calcium containing phosphate binders can lead on to hypercalcemia, which can lower PTH and can result in adiabatic obesity with its attendant risk of calcification resistance. And risk of hypercalcemia is more common if you use combination pills which are readily available in the Indian market. Regarding the non-calcium-based phosphate binders, the sevelamer is a cationic polymer which can bind phosphorus to ionized. It has the additional advantage of bind salt binding capacity, which can reduce the LDL and has a beneficial effect on vascular calcification. Lanthanum is a rare blood which is again is a very powerful phosphate binding capacity, and it is on a wide pH levels. It can act powerfully to bind calcium on a wide range of 20 from 1 to 7. So it is effective in the acid pH of stomach as well as the alkaline pH of the duodenum and jejunum. So an interesting aspect is lanthanum tablet can cause radioactive shadow in the brain external. So this is of concern for me. This is to show the phosphate binding capacity of various binders, of which lanthanum is the maximum, binds 135 mg per gram. Nicotinic acid is a novel agent which inhibits phosphate reabsorption from the gut by inhibiting the transport. It's safe, effective, and is less expensive. It also has an added advantage of increasing the HDL cholesterol. Other phosphate binders are chitosan-based chewing gums are available. Contains biopolymers which can bind phosphorus in the saliva. A word about aluminum containing phosphate binders. Nowadays it is not used. It is used only in situations where there is severe hyperphosphatemia, that too only for very short periods because of its side effects or various organ systems. Next is the usage of vitamin D in control of hyperparathyroidism. Vitamin D deficiency is common in the general population, so also in pre-dialysis patients. It can worsen secondary hyperparathyroidism. So those patients with vitamin D levels less than 30 nanogram per ml, hydrocalciferol may be initiated. So a simple formula to calculate the dose of hydrocalciferol. Every 100 units of hydrocalciferol contains 0.7 nanogram of vitamin D. But one has to be very careful about the serum calcium and phosphorus level, which should be monitored quarterly and discontinued if the total corrected calcium is more than 10.2. The contribution of calciferol deficiency to the development of secondary hyperparathyroidism constitutes the biologic rationale of using vitamin D analogs in patients with CKD. So most patients with PTH levels more than 300 may require vitamin D analogs or calciferol. This is because of two reasons. One is the calciferol is superior to calcium supplementation. Second is the prevention of secondary hyperparathyroidism is easier than treatment of established disease. There are 6 active vitamin D analogs available. No evidence is there to prove the superiority of one over the other. So you can use any one of these analogs depending upon the cost and formula availability. Dose of vitamin D analog depends upon concurrent use of calcium mimetics or calcium containing phosphate kinase. Whether it is used in the low dose or supraphysiologic dose, whether it is used in the injectable form or oral form, or in pulse oral or daily oral, it is found to be equally effective in suppressing PTH levels. The requirement of active vitamin D analogs are found to be greatest during the initial periods of therapy, where more changes of secondary hyperparathyroidism are present. But dose requirement becomes less as more patients start treatment. Dose titration is usually done after 4 to 8 weeks, and parathyroid hormone starts decreasing only after 3 to 6 months of vitamin D analog therapy. So dose should be reduced to 50% if the calcium concentration is 20 or more, and it should be stopped if the calcium concentration is more than 10.2 mg/ml, or one can consider cyanic acid. Contraindication for vitamin D analogs are phosphate level more than 5.5, calcium level more than 9.2 mg/dL, PTH less than 150 mg/ml. An interesting point to be noted is intermittent calciferol, though it is easy to administer and ensures compliance, it can cause adrenaline bone disease, despite persistent hyperparathyroidism, because calciferol can directly suppress the bone formation. So one has to be careful with this aspect. Around 50% of the patients with severe hyperparathyroidism are resistant to calciferol therapy. This is because the large gland with rotilla hyperplasia contain less number of vitamin D receptors. These parathyroid cells which have undergone hyperplastic changes have an altered sensitivity to calcium, or it may be due to the increased phosphorus and calcium produced by calciferol, which is responsible for the hyperparathyroidism. So refractory to calciferol in this system, one may consider calcium mimetics. In refractory cases, one may proceed with parathyroidectomy. So calcium mimetics are small organic molecules which activate calcium-sensing receptors in parathyroid gland. It mimics the effect of increased extracellular calcium. It maintains the pulsatile PTH secretion and is anabolic for bone. Calcium mimetics decreases the serum calcium level. This is by producing a reduction in PTH-mediated calcium efflux from bone. It increases the phosphorus level also. That is by reducing the PTH. In stages 3 to 5 CKD, that is the pre-dialysis phase, those patients who are refractory to vitamin D, calcium or phosphorus levels, calcium mimetics may be used, but one has to monitor the calcium and phosphorus is weekly. The outpatient setting is critical, so currently it is not approved for use in pre-dialysis patients. Calcium mimetics are complementary and synergistic with vitamin D analogs, and definitely it has been shown to reduce the rate of parathyroidectomy by 50%. So indications of calcium mimetics: the parathyroid level is more than 300 mg/ml, calcium more than 8.4. Even if it produces hyperphosphatemia, it is not a contraindication like vitamin D. So start with a small dose and doses increase gradually every 3 to 4 days. And hypocalcemia is a absolute contraindication for calcium release. It should be used with great caution for people with seizure disorder, and also it can cause QT prolongation. So when we discuss the treatment of CKD disease, we discussed under 2 headings. A stepped approach to treatment in the pre-dialysis phase. The first step is to control the phosphorus. So phosphorus may be, dietary phosphorus may be restricted to less than 900 mg per day is the first step. If it fails to achieve the target phosphorus in 2 to 4 months time and phosphate binders, again the choice depends upon the calcium levels. If the patient has associated 25-hydroxyvitamin deficiency less than 30 nanogram per day and hypocalcemia. But again, one has to monitor the calcium and phosphorus every 3 months, and if the total calcium, target calcium exceeds 10.2, stop continuing. In the early phase of CKD, you may observe normal phosphorus, normal calcium, but phosphate retention starts as early as in stage 2 or pre-CKD. But phosphorus is maintained within normal limits. At this time, this is mainly brought about by the increase in phosphaturic hormones, that is PTH and FGF territory. Usually at this point in time, we don't usually measure PTH or FGF territory, which is not available also. So in such situation, better to use small dose of phosphate binders along with meals. That is a question. So if the GRP, once there are 2 schools of thought, one group of experts advocate the use of small dose with meals, phosphate binders with meals, if the total reabsorption phosphorus is less than 80%. But other groups do not advocate this because of the absence of data suggesting it. So this is an article published in CJASN in 2011, which advocates phosphate binders in the early phase of CKD when the GRP is less than 80%. But further studies are required in this regard to confirm its role. So at 6 months, despite dietary restriction, use of phosphate binders and hypocalcemia, if the PTH is still elevated, then one can consider active oral vitamin D analog. Again, that depends upon the calcium level, phosphate level, and close monitoring to titrate the dose. Secondary parameters are resistant to all these measures, one can consider selectivity. But in pre-dialysis patient, it is not readily advocated. KDIGO do not recommend this, and because of the positive data regarding safety and efficacy. In the late stage of CKD, as the patient is initiated on dialysis, those patients who are refractory to diet and dialysis, phosphate levels may be tried. Again, complex balancing of 4 medications, the phosphate level, calcium inhibitors, and vitamin D analog should be used with close monitoring of parameters to maintain the phosphorus less than 3.35.4. The choice of phosphate binders again depends upon the level of calcium. As the patient with CKD reaches end-stage renal disease, dialysis of any mode becomes an additional means of elimination of the phosphorus. Hemodialysis is more efficient with a simple 4-hour conventional procedure removing 800 mg of phosphorus, and about 300 mg of phosphorus is removed by PV daily. But weekly phosphorus removal is comparable to these 2 groups. The phosphate elimination is maximum in first 60 to 90 minutes of initiation of hemodialysis, after which the removal becomes slow. This is because the phosphate is mainly distributed in the intracellular compartment. It is to be transported to the intravascular compartment to be removed by dialysis. This transport is slow, and this is the rate of takes time. Different approaches have been tried to enhance the elimination of phosphorus. So, by increasing the frequency of dialysis to 6 or 7 sessions per week, as with short daily or nocturnal hemodialysis, has been shown to enhance phosphate removal, resulting in either reduction of the requirement or even discontinuation of phosphate levels. So, if it is acceptable to patient, that may be advocated for patients with uncontrolled hyperphosphatemia. Dialysis calcium concentration is again a concern for PTH control when patients are undergoing dialysis. The KDIGO recommends the calcium concentration to be 2.5 to 3. Any level above or below this will require close monitoring of PTH and more protocols. The Hyperparathyroidism, refractory to almost medical management, one can consider parathyroidism if the patient is symptomatic. And severe hypercalcemia, progressive and debilitating hyperparathyroid bone disease, refractory urines, unexplained symptomatic thyroid are other indications of parathyroidism. So if the patient is asymptomatic, parathyroidism may not be done. Again, the weight of the gland is one of the related indications of parathyroidism. Normal weight is 30 to 40 grams. If weight is more than 500 to 1000 grams, like an undergone nodular anaplastic changes, again that becomes refractory to medical management. Again, a few words about CKD ability in children. So it's highly dynamic in brain children, require close monitoring, each different target lives with repeated therapeutic adaptations. In adults, the vitamin D insufficiency is less than 30, whereas in pediatric age group, if it is less than 75, ergocalcium or folic acid are very supplemented. Other drugs which are tried in adults should be used with caution until we get research trial results. So to conclude, hyperphosphatemia is a fundamental control of hyperphosphatemia is a fundamental importance in the prevention of secondary hyperparathyroidism and to prevent the long-term bone and liver cardiovascular sequelae. The phosphate restriction should be started in the early phase of CKD with dietary restriction, and as CKD advances with addition of phosphate levels and the activation which is CSRT by initiation of dialysis. So it recommends the balancing of all phosphate restriction, vitamin D, calcium levels, if not getting control of parathyroidism, secondary hyperparathyroidism should be controlled. A word about protein malnutrition, which is very prevalent in our CKD population. The scheme of experienced dietitian is often not readily available. So as practicing nephrologists, we have to give adequate dietary counseling for our patients because the majority of our patients are unaware of the importance of phosphorus, unsure of the foods high in phosphorus. So each phosphate level has a limited phosphate level capacity. So dosing should be adjusted to the meal size and frequency. So as nephrologists, we have to educate not only our patients but also the primary care physicians who take care of our patients in the early stage of CKD, where the CKD activity is silent, the disease is silent, and CKD activity starts. These are some of the vegetables. The cauliflower is the maximum 250 mg of phosphorus per 100 gram, and the least is cucumber 4 mg. So it is very important to give dietary advice to our patients. Thank you for the patience.
Thank all of you for this wonderful opportunity. I stand before you to speak on three topics of chronic kidney disease and mineral bone disease. One is vascular calcification, second is fractures, and the third one is post-transplant bone disease. We have discussed about this earlier. The main advantage of shifting from the diagnosis of renal osteodystrophy to a CKD activity is the inclusion of the third and the most important aspect of the definition, that is the vascular and the soft tissue calcification. The vascular calcification is otherwise called as uremic calcific arteriolopathy or calciphylaxis. It's a disorder of small vessel calcification and it is associated with the progressive development of cutaneous plaques and ulcers secondary to ischemia because the vessels are occluded because of the medial calcification. And the estimated prevalence is between 1 to 4% in end-stage renal disease. It is not quite new to the nephrologist as far as the topic is concerned. As early as 1898, the relationship between cutaneous gangrene and vascular calcification was described, and the term calciphylaxis was coined as early as 1962 by Sale and Lewis, where it was defined as a condition of systemic hypersensitivity induced by sensitizing agents that resulted in metastatic calcification in various organs upon re-examination. The calcific uremic arteriolopathy was defined by Coase, and in 1976, the syndrome of calciphylaxis was proposed by Gibson. This is the Sales animal model where they have reduced calciphylaxis by demonstrating the significant vascular calcification in the aorta animal model and the medial calcification, what they have demonstrated in histology. In fact, we discussed about this topic in the morning, the difference between an intimal calcification and the medial calcification. predominantly mediated by the vascular